Okay, we are here to talk about the drugs of the peripheral nervous system, and we're going to start with looking at the cholinergic drugs. And these are drugs that are going to directly or indirectly increase or decrease the action of acetylcholine at muscarinic and nicotinic receptors. So I'm going to break this down by category so they don't get too lengthy. And I'm going to start with the drugs that have cholinergic effects. So the drugs that have cholinergic effects are drugs that are going to either stimulate or block the muscarinic receptors or the nicotinic receptors. So when we think about drugs that I guess the parasympathetic response, then we're going to want to think specifically about the muscarinic receptors, because those are the receptors that are at the targets of the peripheral nervous system. And of course, the targets are the electrical conduction system of the heart, most notably the smooth muscle of all hollow organs and glandular tissue. So when we think about drugs that affect the GI tract, the genitourinary tract, and also the eye again, remember, is dually innervated, but the eye pupil, it has the parasympathetic and the sympathetic nervous system affect eye pupil diameter, and also focus is largely under the control of the parasympathetic nervous system. And then, of course, if we are trying to use a peripheral nervous system drug to interface with our skeletal muscles, then our only option is the nicotinic receptor. Of course, the nicotinic receptors are everywhere. They're at the ganglia, they're at the adrenal medulla. So using the nicotinic receptor as a point of control, I guess, is probably not desirable with few exceptions. And a notable exception to that would be, again, if we were trying to control the skeletal muscle. So kind of how this is set up, you notice there's things in red. The things in reds are names of conditions, mostly to illustrate the point. Kind of when you start learning about these drugs, again, if you're solid on the organization at this point and you know the difference between sympathetic and parasympathetic stimulation, and you have an understanding of what dual innervation is all about, memorizing bunches of conditions shouldn't be necessary. You should be able to use your knowledge and then just try to think if the drug may or may not be effective, given what you already know. That's how I would suggest doing this. But I give you conditions just because sometimes it helps to just make the point or have some sort of conceptual framework to hang some of this information on. All right, so what we're going to do first is we're going to look at the muscarinic or cholinergic, or sometimes muscarinic cholinergic agonists. So these are drugs that are going to stimulate in some way the muscarinic receptor, or they're going to increase the action of acetylcholine so that we get more hitting of the muscarinic receptors. Remember, when the acetylcholine hits the muscarinic receptors, it promotes the rest and digest system. So we really want to think about these drugs when we want to increase the muscle tone or contraction of the GI tract. So an example of a condition that where this may be useful is if somebody has post-operative ileal retention. There's almost no better way to slow down the gut motility than use pain medications. And so with post-operative ileal retention, we most likely have that kind of a thing going on. Okay, so these drugs, in addition to increasing muscle tone and contraction at the gut, they're going to do the same thing at the genitourinary system. So you can see that on the slide, post-operative urinary retention, or just kind of urinary retention in general. Their muscarinic agonists can be used to stimulate exocrine glands. That should make sense to us. So drugs that increase salivation, if necessary, increase lacrimal gland secretion. So people with dry eyes, that's what xerostomia is. Sjogren's syndrome is an autoimmune condition in which there's a lot of drying of the mucous membranes in general. So Sjogren's patients are most likely going to need some support there. So any kind of increase in exocrine secretions, muscarinic agonists will do that, whether you want them to or not. So when we get to the eye, so the eye, remember, there's the radial muscle of the eye, which is like, the fibers are arranged like spokes of a wheel, and then there's the sphincter muscle of the eye, which the fibers kind of arrange like this, sort of like a circle. So those sphincter muscles are the ones that are under the control of the parasympathetic nervous system, and when they are stimulated, it causes those fibers to shorten, which causes the pupil to constrict. So with parasympathetic stimulation, we get constriction of the pupil. The fancy word for that is miosis. And so these are oftentimes used topically if you need to constrict somebody's pupil. They're used for glaucoma as well, because if you look at that final bullet, they also cause contraction of the ciliary muscle, which causes the lens to actually round. That's written wrong. But it and blurs near vision. So the other thing that also happens here is when you constrict the pupil and you contract the ciliary muscle, that will promote drainage at the canal of Schlemm, and it will take fluid out of the anterior chamber of the eye, which is where they are sort of useful for glaucoma. So lots of options here. Again, if you just kind of think about what you know about the parasympathetic nervous system, you should be able to be like, oh yeah, okay, I could see that, how that might work. All right, when we think about the side effects of these drugs, we definitely are going to think about GI and GU motility. If that's not why you're using them, anticipate that happening. So cramps, diarrhea, nausea, excess salivation, that's probably one of the reasons why the use of these drugs is so limited, because it does stimulate the gut so much. And if somebody doesn't have, if somebody's not having a retention issue, then this might be too much for them. A little bit of vasodilation, sweating is quite common because, of course, there's muscarinic receptors at the sweat glands. Again, we just mentioned the blurring of the near vision, the blurring of distance vision. I hope I didn't say that wrong on the other slide. The inability to see really like anything other than at a fixed point, and constriction of the pupil. We didn't talk about this, but the airway, the smooth muscle of the airway, is dually innervated, and the muscarinic side of this causes constriction of that smooth muscle of the airway. So if somebody already has an issue of a narrowed airway, like an asthmatic patient, these drugs are not oftentimes indicated. And of course, they're going to decrease the heart rate, which we already would expect, which would then lower the blood pressure. And anytime the blood pressure lowers suddenly, that can cause a reflex message to the brain because of the baroreceptors that are located at the aortic arch and also the carotid sinus. But they're very sensitive to a change in blood pressure. And anytime the blood pressure changes suddenly, that's registered in the body as an emergency, whether or not it really is. And so that then sends a reflex message back to the heart that says, get this thing going. So that's why the heart rate can go up. Generally, they'll adapt to that after the new pressure has sort of been accepted, and it will go away. But it's quite common with any drug that lowers blood pressure. And we'll revisit that in Unit 5 quite a bit. So here's our parasympathetic system, salivary gland, smooth muscle of hollow organs. Also, we've got a muscarinic receptor at the sweat glands, like we talked about. All right, so here's some examples of some of these drugs. When we see direct and indirect, what that indirect means is when a drug is indirectly acting as a cholinergic agonist. What that means is that rather than stimulating, causing either the increase in acetylcholine release or the drug looking and acting just like acetylcholine at the synapse, instead what we can do is we can inhibit the enzyme that breaks down acetylcholine. So if you remember, acetylcholine gets broken down almost immediately in the synapse itself. There's an enzyme there called acetylcholine esterase. And acetylcholine esterase, or sometimes it's just referred to as cholinesterase, its job is to break down acetylcholine in the synapse to its bits and pieces, and then the bits and pieces get recycled, and then they get sucked back into the presynaptic neuron, or in the case of the parasympathetic, the postsynaptic neuron, and then get rebuilt again, and then the acetylcholine can be released again. So if you give a drug that acts by inhibiting the acetylcholine esterase, What that means is it leaves the acetylcholine there viable in the synapse longer, which then will stimulate the receptors. So it's an indirect action, but the net effect is that of a cholinergic agonist. So hopefully that makes sense to you guys. If not, you might want to rewind to the part where we talk about the breakdown of acetylcholine, and I believe I talked about that there in one of our introduction videos. Okay, so that's it for the muscarinic agonists. Really quickly, I'll talk about the nicotinic agonists, and then we'll do the antagonists. So nicotinic agonists are not going to be used that much because they're super unreliable because of the fact that we have nicotinic receptors everywhere and we don't have any way to differentiate between them. So you'd fire off the ganglia, so there isn't really any use for nicotine as itself on its own. The only real use for nicotine or a nicotinic agonist is for the replacement of nicotine, and usually that is during smoking cessation programs. So you can see there's the gum, Nicorette is one, there's the transdermal patches, Nicoderm is one, there's nasal spray, Nicotrol, there's another. So that would be specifically to replace nicotine at the synapse. Short of that, like if you wanted to contract skeletal muscle, this would do it as well, but there's other drugs that are going to do that. And the reason why we don't want to use a nicotinic agonist if you have other options is because you're going to see all the effects of the ganglia, right? So you're going to see maybe parasympathetic, maybe sympathetic, maybe both, but then you'll get the benefits of the nicotine, which is, increased alertness, increased heart rate and blood pressure, stimulates the emetic center in the brain, which can cause nausea. Again, this is just a side effect of these drugs that oftentimes are used in smoking cessation products. If somebody were to ingest huge amounts of a nicotinic agonist, that could cause respiratory paralysis. I'd worry about that more. It's unlikely in an adult, but I would worry about that more like if the kids got their hands on the Nicoderm or the gum, or an animal, for example, got into something. I would worry more about it along those lines. I don't think that an adult would. It's possible for sure, but it's not as likely. Okay, so let's stop here, and I'm going to come back in the next video and I'm going to talk about the antagonists. So I'll see you there.